Broadcasting from Baltimore, Maryland, this is 5x3 Radio, where strength is for everyone. I'm your host, Emily Sokolinski, owner of 5x3 Training, a strength and conditioning gym in Baltimore, along with my co-host, Rebecca Fishburne, founder of Cornerstone Strength Maryland. Each week, Rebecca and I will discuss the ins and outs of strength training, why there is a no one-size-fits-all approach, and why strength is so important in our daily lives. Thanks for spending some time with us today. Now, on with the show.
So, what do you have on there? Like a bunch of Taylor Swift bracelets?
No. Hey, there we go.
Okay.
Hey, Fred.
All right. Hi, Fred.
Hi.
All right.
So I didn't know that you guys did a video podcast.
It's not a video. We just make videos.
Oh, okay. I was like,
no, we don't.
Because I was like, I've never watched their podcast before.
Yeah, this is how I can tell if Emily starts pounding the desk, and then I have to tell her to stop because it's too much background noise.
Yeah.
No, I keep her under check this way.
I've learned to sit on my hands. The minute I start, she says, "You're doing it again." We started doing the Zoom because we actually missed seeing each other for one thing. So that was a nice way to see each other in 2020. And then I just take the audio version, and we're just discussing how I'm able to split all three of us. So I'll get all three in individual audios.
And then you can get the levels right.
Exactly.
Yeah, she's got a fancy mic.
Exactly.
No, I do listen to shady podcasts where I have to turn it down or up depending on who's talking. And
yes. So that was
stand for that.
Yeah. So in the beginning, I mean, if you go back and listen to our very first couple episodes, they're really rough. I think we were recording on our phone. We see each other, but we recorded our
this for it. This works on my phone, but it didn't work on.
We used to use the phone, and then we decided just to try to use the Zoom audio, and actually that was really nice. And then I got my fancy microphone, and then I could actually split the audios into 3 different audios or 2 different audios. So.
Oh my God, you guys are both so serious about this.
You know,
well,
look at that microphone.
I do telepsychiatry. It's a
there you go. That's right.
I thought it was like a Freudian thing there. Whose microphone was bigger than whose?
No, it's just seeing if Emily and I are equally crazy about that. And then you got to get a cloud.
Yeah, you guys both. I totally have microphone envy.
You have to get a cloud lifter preamp, and
I told you I could get you a microphone if you wanted it, and you said no. But I mean, I'm happy to do that for Christmas. I'll do it for Christmas.
Having all these technology.
Whatever CNET sells for $100 will be fine.
All right. Hi, everybody. Welcome back. 5x3 Radio. Rebecca and I are here. And we have a very special guest on our show today. Dr. Fred Houts is with us, and we've been kind of talking about this for, I guess, a few months now. That we wanted to have him on the show. We did. In fact, one of my members today was
no pressure, Fred.
Was looking forward to this. Fred reached out to me back in May. We had done a podcast on mental health and strength training, and he reached out to us and said, "Hey, if you've ever want me on your show to discuss this in more detail, I'd love to be on it." So here we are. Finally, we have him on our show today. So. Fred, I want to turn it over to you and introduce yourself. Give us an idea of your background, and you take it from there.
Sure. So I love Baltimore. I lived there for 6 years. I really wish 5x3 had existed when I lived in Baltimore. As you said, I am a psychiatrist. I've been fellowship trained in forensic psychiatry. I did a residency and chief residency at the Johns Hopkins Hospital, and I also picked up a board certification in addiction medicine. So I'm certified in general psychiatry, addiction medicine, and forensic psychiatry. Forensic psychiatry just means I'm good at going to court and arguing about legal stuff when I have to. And some of my patients are at maximum security facilities and have done unsavory things. And my career has given me a great adventure. I've been all over. My first real job was in Anchorage, Alaska, and I've done high volume inpatient work in California. I've been living in Minnesota for the last 7 years. Worked in New Zealand for a little while. So I've seen my strength is that I've seen a bunch of patients, inpatient and outpatient. I'm well versed in mood disorders, psychotic disorders, most sorts of mental health issues that could ever come up anywhere. And the thing about that sort of training is it was really arduous. And so all of my 20s was, I got to get through training. And then in my early 30s, I suddenly had time to actually go train. And so I got the blue book and learned what a deadlift was. And then I was going to a boot camp in Anchorage, Alaska. And then I realized like the only stuff I actually am pretty consistent about is barbell training. And then I went to a starting strength camp and so and then my wife is a recovering runner and she's incredibly competitive, and she's also an internal medicine doctor with a subspecialty in geriatrics. And so she has really long arms and can pull almost 300 pretty regularly. And so we have a basement gym and all that. And so I've always loved your podcast. And then I heard you were talking about mental health. I was like, oh, I know a thing or two about mental health.
And you came, remind me, but I think that we had just moved to our new location when you were in Baltimore. And
you're kind of by Bayview,
came by,
restaurant.
and visited us and worked with Craig.
Yeah, because the forensic psychiatry conference was in Baltimore before the plague, and I came by and worked with Craig, and it was great.
Yeah, it was fantastic, and that's how we first met you and learned all about. Great. Yeah, I remember that very clearly because it was because you kept in touch with us after your session with him. So I knew that when over the past couple of years you've emailed me here and there. So what made you reach out to us after our last podcast that we did?
I'm something probably of a starting strength tourist. So I've been to starting strength gyms in the Pacific Northwest and a couple in Texas and one in Nebraska. But I just love Baltimore. I would live there if I could. You answered a couple of my questions on some earlier podcasts. And,
we did. Yes. Yeah, I remember because actually we had Diego on. That was how we got Diego on.
I got Diego on. Yeah.
That's an accomplishment.
There's a lot of people that get into strength training and say, oh, I used to do this in high school, or I used to be on the football team. And I was just always a runt and a shrimp and got picked last back when they picked teams. And I was always a brainy dude. So I just kind of focused on that. And then I woke up and I was in my early 30s and weak as a kitten and threw my back out all the time.
Yeah. I've been there. That was me. I mean, that's why I started lifting. Actually, that's exactly why we started. Diego started before I did because of his back. Yeah. As a runner.
Fred, like you're talking about like the brainy appeal of the starting strength, the discussion about the mechanics. Like one of my more recent clients was a physicist. And so like the physics of it was like really interesting to her. So
right. Yeah. And it's also the fun part of it for me was, I never thought I was gonna bench press a 135, and then I was doing 225, and then oh my gosh, for my birthday, on my 45th birthday, I pulled 450 for 5. I was like, oh, this is like a thing I do now. So, and it awesome. Changes. I've written a little bit about this, but I mean, it changes sort of how you carry yourself in the world. And I work at a maximum security facility with people that are murderers. And luckily I have a lot of big Minnesota farm boys that their job is to protect me, but it's also, I had a patient punch me in the throat a couple months ago and I didn't really feel it.
Jiminy crickets.
So one of our coaches, who's been with us since 2014, Jay, we had Jay on the podcast, I guess way back in the beginning, talking about his experience as working at Kennedy Krieger in his job as a behavioral specialist. What he deals with was just little ones. I mean, I can't imagine grown adults,
right.
In your personal space, in a day. He has like 7, 8-year-olds, but they can do some damage.
No, KKI deals with really violent kids with really severe autism. And sometimes they would bring them to Johns Hopkins for ECT treatments. That's electroconvulsive therapy, which I also do. And so it's very dangerous and difficult work, and it's got a huge burnout rate.
Yeah. No, it's amazing how long he's been there. I mean, he's teaching new teachers because there's such a rotating door. They come, they go, they come, they go, they come, they go. And Jay's kind of like that permanent fixture because he knows what he's doing and he knows how to handle himself. So talk to us about what did we say or not say, I'd say, in our podcast back in May about mental health? Because this was more coming from Rebecca and I and our experience.
Yeah, but both of you said, "Oh, well, I'm not a psychiatrist, and this is stuff you need to talk to your doctor about." And what I'm always dealing with is because I'm the way I am, I wind up being everybody's psychiatrist. And hey, my mom has depression, or I'm on this much sertraline, and what do you think? Or I heard on a podcast that all I need is testosterone. What do you think about that? So there's a lot of misinformation that it really requires the breadth and depth of an education that took a decade to kind of get into. And there's a lot of misinformation. I think a major part of what I'm interested in talking about is how common mood disorders are and how treatable they are. I don't have any books to push. I don't have a podcast I'm selling. I just think it's something that's really common and really treatable. And there's a lot of misinformation about it. So, I mean, for example, I have a patient who's a fifth-a-day drinker, and who says, well, I'm not taking any of your medicines or quitting drinking. I just need my testosterone supplemented. And I'm like, well, let's start with your hierarchy of needs and right. Go from what we can do reasonably. So I think that psychiatry has always gotten wrong whenever you see a movie or a television show. So people don't really know what I do. I mean, everybody thinks you're Woody Allen on a couch or something, but 4% of the population has major depressive disorder, which is a very treatable condition that absolutely colors everything about how you move and work in the world and makes training really hard. 1% of the population has a bipolar spectrum illness. 1% of the population has schizophrenia. And particularly with men, there's always this stigma about getting treatment. Women, for whatever reason, there's some literature that says women are more represented with regard to mood disorders, but there's also been a longstanding thought that there's a huge selection bias in that, and men just don't get treated for it as much. And there's also the proliferation of pop psychology and therapy. So lots of podcasts are doing ads for BetterHelp, and that's not a bad thing, but there's lots and lots of therapists from all levels of education and training, and there's a lot of psychiatry that's actually done by primary care physicians and primary care providers. So the question is always, what do you do when you're starting to have that problem, and where do you even go for your first phone call or first appointment?
So can you walk us through that? Can you talk a little bit more about that?
I think the most helpful thing might be to just discuss the phenomenology of major depression. And when I talk to patients, I tell them it's three things. The first criterion is low mood. But do you have a low mood because your pet died or your parent died? Or do you have a low mood because you just can't get out of it? So a question I will commonly try to figure out is this person suffering from little d demoralization, or big D, the illness of major depression, where if your life circumstances were ideal, you still just don't feel like you can enjoy things. The part of your brain that lights up when you've had a great meal or a great date or a really fun evening doesn't work. And so that's what people maladroitly will call a chemical imbalance, but that's something that we want to try to go after with medications. The second criterion is poor self-attitude or an impaired self-attitude. And this is pretty elusive because it's so person dependent. But for example, a young mother with postpartum depression might say, I'm a bad mom, or I'm not ever going to be a good mom. Or men will say, I'm useless. Some people will have just this overwhelming sense of hopelessness and nothing will ever be right again. And the third criterion is something called vital, VITAL, vital sense, which is poor energy, poor concentration. So that's when, oh my gosh, I just squatted 315 last week and my warm-up set of 225 feels like I've got a car on my back. Or I've been staring at the spreadsheet for 3 hours and I don't think I've done any work. And a lot of things can look like and smell like major depression, but if you've got those things, and if it's been episodic, if you have a family history of some sort of mood disorder, it's worth getting treatment. And you don't need me. You don't need a triple boarded Johns Hopkins trained psychiatrist to do it. You can go to your primary care doctor and probably get started on an SNRI or SSRI or bupropion or mirtazapine or any number of antidepressants. And about 2/3 of cases of depression are treated in the primary care setting, and they do a very good job about it. So I tell my residents and medical students, if you think you're going to buy a house prescribing escitalopram for people who cry in your office, that's already been taken up by someone who's getting paid a lot less than you. So whatever reason, I have a much harder time having this conversation with men, and I don't know why.
Yeah, I think that goes to the just even therapy too, right? I mean, more. I mean, I don't know this, but I feel like I know just personally, people in my family or people or friends of mine, men are definitely less likely to want to seek out help, whether it's asking for directions or getting mental health. I guess there's a stigma of we just need to snap out of it. Like, I need to man up. I need to just take care of this myself. I don't need the help. I mean, I had that in my own personal life with a family member, and it's been very detrimental to him as well as to his children. That's a good question. Like, how if you don't know the answer, what is it about? Is it men versus women? Is it just our psychology? Is it just our emotional output?
I kind of think so. I went to undergrad at UC Davis back when you could go do stuff like see Kurt Vonnegut speak for $10. And Kurt Vonnegut said masculinity is a very fragile thing, right? So you can think about just the extremes of that. If a man loses his job, he doesn't really feel like a man anymore.
Right.
If a woman has horrible, terrible types of cancer and get stripped of all of the feminine attributes that we can still consider feminine, she's still a woman. So I think also there haven't really been any great spokespeople for men with major depressive disorder. I mean, we kind of had Terry Bradshaw for a little while, but then he said, no, I'm fine now. I just have stimulants. And so I can't pass out that Sports Illustrated article from 15 years ago anymore. And there's as I said, the people expect that I'm going to have them lie on a couch and free associate, which is not usually what I do. Actually, I don't think I've used a couch.
So can I ask two questions then? Like of your clients, like how do they skew in terms of male, female, and then also how would you describe if lying on a couch and chatting isn't what happens when someone comes to work with you? What would a typical session be like?
So I'm always full and always busy. That's why it took us a couple of 3 months to get this podcast sorted out. So I actually have a pretty even split of men and women in my practice, but a lot of my patients are really, really ill. And so that's no longer in the realm of, okay, this is a guy who's not feeling so good and just needs a little bit of help. It's more, I'm hearing voices and I'm disorganized and the court has ordered me to come see Dr. Houts. And that's a different kettle of fish. So what I like about the job is I see everyone from, I mean, I've seen White House cabinet members to homeless veterans to people that are in and out of jail to murderers. It doesn't really matter to me. But when it comes to, let's say, someone who would be seeking the services of 5x3 and is a man with a low mood or a woman with a low mood, the men take a little longer to get treatment. Some of that is changing because there's more guys are coming out of university with some experience with student mental health, and the treatment is trial and error, unfortunately. So there are all these fancy pie charts you can do saying, oh, my genetic test came back and said these drugs are in the green column and these drugs are in the yellow column and I need to try. Well, all those tests do is tell you what your liver is good at metabolizing. They don't tell you what your brain is good at responding to. So when people come to see me for the first time, the first thing I do is a 1-hour evaluation. Sometimes it takes more than an hour, sometimes it takes less than an hour, but I do a semi-standardized interview, which is, do you have a family history of mood disorders? Do you have a family history of suicide? Where were you born and raised? How far did you get in school? Did you skip any grades or repeat any grades? Did you grow up in a well-to-do family or in a more poverty-stricken situation? And when do you think your first mood disorder happened? And when was your first depressive episode? How long did it last? Is it bad enough that you got suicidal? how many suicide attempts have you had? And so obviously I'm talking as if I deal with a lot of sick patients, but you also are very surprised sometimes at the answers you get when you finally do the interview on someone who looks very, very put together, and you find out, oh, this guy was a blackout drunk in college and he's tried to kill himself 2 times, but he was drunk both times. And you want to put together a narrative of what makes sense. And then you really need to come up with a diagnosis. So is this regular old major depressive disorder that 4 people out of 100 get, 1 people out of 25? Or is this somebody who had a tiny little stroke and nobody picked up on it? Or is this somebody who really has no mental illness at all, but is in a profoundly demoralizing situation? So once you have the diagnosis, then you can come up with the plan of treatment, which may or may not involve medication. But to be blunt, by the time people get to me, they've usually flunked a couple of psychiatrists and a few primary care doctors. But the core skill set is, okay, now you've got this diagnosis of major depression. Let's start with some medications. And then the job is pick a medication based on side effect profile, get it up to a reasonable dose, see if it works, and keep seeing the patient until he or she is 100% better. And so that's why I find it very rewarding. I mean, 90+% of my patients that show up consistently get back to their lives and have really, really good outcomes. And then to the point where I'm like, okay, I've refilled your meds for 6 months or 12 months and I haven't seen you. How are you? Oh, I'm fine. Or I'm feeling fine now. I'd like to stop these medications. And that's a different conversation.
Yes. Yeah. I know that was me last year. Actually, I don't know if I talked about that did I talk about that? That I thought that was me last year. Yeah, September, around a year ago now. I decided, I was running out and I didn't, get a refill. I'll just go off of it. I'm okay. I feel so great. I don't need this. And it was a very small dose that I was on. Well, about a month later, when I was at the gym, Diego says to me, I think you might want to go back on the medication. And I was always like, really? You think so? Because the world was coming down around me. It was coming down around me. And then, and when I went back on it, it just, everything leveled off again. So it's not, and I live with somebody, I'm married to somebody who is very matter of fact, very scientific in his approach to everything. And it's good when you have that kind of support coming from your spouse. Do you encounter that with your patients who don't have a partner or a spouse who is against this approach?
You brought up at least 3 things I want to get into. So the first thing is, if your mood disorder is adequately treated and you stop all your medications, you will absolutely feel better for about 10 days. Everybody feels better for a week and a half, 2 weeks, and then a few weeks later, like I screamed at my kid and I don't know why. So, and irritability is a really non-specific symptom, but it generally tells me, okay, you're not acting like yourself. And if you have one question to ask somebody with a mood disorder, it's, do you feel like your old self yet? And that can get really challenging if you have someone who's been depressed since age 13 and they don't know what their old self is, because that's a different kettle of fish. Another thing that you mentioned is that you're on a small dose of medication. So I inherited a lot of outpatients throughout my career where I'm like, what is this person doing on 25 milligrams of sertraline or 10 milligrams of nortriptyline or 7.5 milligrams of mirtazapine? What's the point? Let's just get rid of it. And then you get rid of it, and 2 months later they come back and they say, I'm not sleeping. I've lost 5 pounds that I didn't mean to lose. I yelled at my kids and I didn't enjoy a visit with my family. And you're like, oh, okay, well, I guess that was doing something. Let's restart it. But that's always been the fascinating thing to me about psychiatry, that's so intertwined with personhood. And so everybody's like, oh, it's just like taking insulin for your diabetes. Kinda, but you can have a blood sugar of 300 and still feel completely like your old self and like a normal mental state. And that's a difficult conversation. Well, it's your illness, but it's you, but it's your illness, but it's you, but it's your illness. With regard to families not necessarily agreeing on treatment, I mean, most of my patients are adults, and they make their own decisions, but there is a lot of negative feelings about medications, and usually I encounter those on the individual patient basis. So it used to be that I would have a lot of patients that say, oh, when I'm at my girlfriend's house, I don't let her see the pill bottle or something like that. And that's actually been less common. The most common objection is, do I need to take this forever? Or, I don't understand why I have to take pills to feel normal. And that's the more day-to-day ubiquitous objection. And so I always drag out the data that show, okay, if you've had one depressive episode, the odds are 50-50 you're going to have a second depressive episode. If you've had 2 depressive episodes, the odds are 2 out of 3 you'll have another one. And if you've had 3, the odds are 80%, and so on and so forth. So most of my patients say, look, you bought yourself a lifetime of medications, and I'm really sorry, but one of the few good things about living in 2023 is we can actually treat mood disorders. And, I know it's a pain to go to the pharmacy and you have to see me a little bit, and I'm not free, but don't you like having a job and sleeping?
Yeah. I mean, this is very, you being on the show today is just has come together for me, because actually full disclosure, I had a doc's appointment yesterday, virtual, with my primary to ask her to up my dose.
Sure.
I'm at a place where a year, I mean, this was 2018 when my niece and my nephew moved to Colorado. And it was, my doctor at the time said to me, you've tried the non-pharmaceutical approach with your lifting. Sure. Maybe we need to try the pharmaceutical approach. And at the time I was like, you know what? Yes. Because I was one of those people who was like, I don't need help. I don't need this. I can do it through my training. And fast forward to now, kids are older, things are more, a little bit getting harder to deal with. My brother-in-law. And I said to her yesterday, I was like, I think I need to up something, because it's not quite working now. I was on such a low dose, and it's just a little bit more of kind of like turn the knob up just a bit, and maybe then turn the knob down as needed. And I'm definitely at a much different place in my life where I can say, you know what, this is definitely helping, and I can get through my day, and I can get through my work and my training. And without it, I have a much harder time. And it wasn't like that, how many years ago, but recently. So right. So you talking about this is just what I went through yesterday. With her.
I do this every day, half a dozen times before lunch. I mean, this is, people are obviously ambivalent about treatment, because there is absolutely that feeling of, I can grit through this, and this is some moral or characterological failing on my part.
Right.
And if there's milder cases of depression, not everybody gets suicidal and hears voices telling them that they're worthless, right? I mean, there's a lot of people that just I have low energy, I can't get out of bed. And you're always weighing, should I treat this or not as a physician, right? So I've got 60% tears in my left rotator cuff and my supra and infraspinatus. And my orthopedic surgeon said, yeah, we got to go in there and fix that right away, and you'll be in a sling for 8 weeks. I don't have 8 weeks to be in a sling. I have 4 kids. I have multiple jobs. This is crazy. I will go do PT, and I did PT, and it doesn't affect my day-to-day life.
Right.
Shout out to John Petrizzo. But for example, sort of the paradigmatic example of weighing treat or not treat we were given in residency was, there was a lady who would get hypomanic for about a week, about every 2 years, and she would do something like paint the guest bedroom hot pink. She didn't really have any depressive symptoms. She never got psychotic. By psychotic, I mean disorganized, hallucinated, or delusional. She never got that ill. She just would paint something weird colors. And you're like, well, am I going to put her on lithium for 4 decades over that? No. Is your depression something that affects you for 3 days a year, or for 3 weeks a year, for 3 months a year? So and then I have lots of patients who have 0 side effects and say, oh my gosh, where's this medication been my whole life? And I also have other ones that say, you know what? I'm getting sexual side effects. It takes me longer to get where I'm going. I'm taking Viagra. My husband's taking Viagra. What is this poison you're giving me? And you have to have that conversation. Mm-hmm. Do you want to, well, have you really tried everything? Is this really the right medication? Will we try something that might be less effective but has fewer side effects? And I've got books full of all the medications we can try. I mean, I have my favorite half a dozen that I use first, but it's every patient is his or her own pharmacological trial.
So So you've sort of talked about like you've described like what an initial consult would be like, an intake appointment, sort of checking in with a patient who maybe you've put onto a medication, seeing what the side effects are, trying to decide if that's the appropriate medication, appropriate dosage, if there's something else that might be better. What else is like a component or entailed in working with you besides the pharmaceutical
Sure,
aspect?
absolutely. So I do psychotherapy. I don't have a lot of patients that I can really do the in-depth every week I see you for 50 minutes and I mean I love doing it. I love doing dynamic therapy. That's where we talk about your mom and talk about your dad. And the best explanation I've had about it is the two of you are going on a hike. Me, therapist, you patient. We go on a hike together. And I say, hey, did you ever notice that whenever you pass an oak tree, you always want to turn left? Is that something you always do? Or did you ever notice if it's someone who's an incredibly bad person for you to be dating, you always find that incredibly appealing? And so you're kind of acting as a guide. And the goal of psychotherapy is mastery, right? Like, and there are certain things that I've given up on being a master. So I pay a starting strength coach to do my programming because I would mess my programming up. I don't have an objective enough view, but my starting strength coach can say, you know what, you just got back from vacation. You need to deload a little bit, and then we're gonna start. I know you think that you can do it, but you're just gonna put yourself into a training hole, and you're never gonna get recovered if you go do what you think you're gonna do. So this also leads Rebecca to a lot of what's called split care. So I will often have a psychologist or a master's level counselor do the therapy because I've got a bunch of people that need medication management. And so I will do a half-hour medication check and do whatever psychotherapy I can do in that time. Often it's about what to expect on your medication or your ambivalence or, but a lot of times we've had that patient in and out of the office for 6 times in a year and we know each other pretty well. And then we can talk about, you need a lawyer, or do you really need to get divorced? Or, and I'm not necessarily proscriptive, but I'm not a open-ended question, blank stare psychiatrist. I like to try to block and tackle for my patients.
What, in regards to strength training, Fred, what are your thoughts about, I guess, that exercise and the benefits of that with, medication, therapy?
Sure. So first of all, the worse your severity of illness is, the better you're going to respond to medication as a general rule. There are a lot of people that are moderately demoralized and very mildly depressed. And if they are assiduous about getting up at the same time every day, getting their 7 or 9 hours of sleep, working a program, making sure they get out with family and friends, making sure they're lifting 3 days a week and getting their cardio or conditioning in, a lot of times that's great. There is a subset of patients where their illness is too severe. And I'm like, listen, you can go to psychotherapy 3 times a week and you can do 2 hours of cardio a day. You're still eventually at some point trying to paint this wall with a ballpoint pen. It's the wrong tool. You need to reach for the pills. So that I don't want to, and Hopkins is known for being a biological program that's pills, 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 pills. I don't want to come across as just doing that. It's just my selection bias because my patients are really ill.
Right.
Now, there are a lot of patients that do well with really rigorous self-care, or maybe really rigorous self-care and they're on a teeny tiny dose of antidepressant. That's great. What I will say is there's a whole subsection of psychiatry called, behavioral health, and that deals with what, for lack of a better term, things that people do to themselves, like anorexia or excessive alcohol use, heroin, diabulimia, all sorts of things like that. And so there is absolutely a behavioral component to getting well. And I can say for myself, when I hate training, I've never liked it. I surprise a lot of people at that because I haven't really missed a session in 3 years. But aside from a death in the family or whatever, I'm really on top of doing it because it's important. But right. I hate it. I never think like, oh, you know what would be good right now? Going down and doing a low bar back squat. That would just really make my day. It's never happened. And so doing that, yes, you're going to release all sorts of endogenous endorphins and things that hit your opioid receptors, and you'll feel better. But you'll also have sessions that are just really hard if you have an undertreated mood disorder, or if you're not getting sleep. I mean, we've all had those nights where we tossed and turned and walked into the gym and we slept about 3 hours, and oh, how am I going to do this? Is there enough coffee in here?
Yeah.
So it's just a really good way to take care of a lot of things. There's an evolving and decent literature about benefits to mental health, benefits to overall physical health, how muscle mass is a major way to stave off aging, and I believe in all that. So that's why I do it, even though I hate it.
So people who say to you, "Oh, then my exercise is my therapy," you're like, "Yeah, not me."
Well, they don't come to me. if their exercise is their therapy, then they're doing great. They don't need me.
Yeah.
That's okay.
No, it's I think you hit on a point there, which is obviously, what I discovered that, if the training was, I enjoy training, and it is something that I need to do. I guess maybe as a dancer, I've moved my whole life. So the thought of not moving in some capacity, I don't even think about that. It's something I do, but there was clearly something underneath that wasn't working, because I would have bouts of times where I just was in so much pain, and it was physical. And at the same time, it was probably a lot of mental, that was happening to me. And that was why my doctor said what she said when she kind of hesitantly said, you tried the non-pharmaceutical approach. And I thought to myself, I get it. I get what you're saying now. But it was kind of like one of those things, like I can just push through this.
And it's also something that comes up in psychotherapy. Let's say you have someone who really just had a lot of character and heart and was suffering from a mood disorder, and maybe this patient was cutting herself for years, or secretly drinking more than she ever let her husband know. And it's not at all unique to women, but you get that person better on an antidepressant and they say, oh my gosh, what did I do with the last 15 years of my life? Why didn't I just take care of this? Like, what am I? And there's this sort of a grieving process for the lost time that was you don't get that time back.
Yeah. So earlier you were talking about like just the environment in which we live, and there's a lot of misinformation about mental health or therapy or medication. What do you think is the biggest, most detrimental or harmful piece of misinformation that's floating around out there?
I think that psychotherapy has gotten overly complicated. So there's people that say, oh, I need to see an EMDR specialist, or I need to see it's just eye movement type of therapy where you cross visual fields, or you have vibrating eggs in each hand and your neural pathways cross, and that helps. Or there's a trauma specialist therapist, or there's a trauma debriefing therapist, and so really, Jerome Frank wrote a book called Persuasion and Healing, and there's only two things that are necessary in the psychotherapeutic relationship. One is on the part of the patient thinks that the person he or she is seeing is an expert. And two, the patient expects to improve and heal. So you could go to a cosmetologist and get a great haircut and say, I'm going to go see Sally and I know I'll feel better after this. And if you feel that way, and Sally's done a great job on your hair 15 times, that's going to happen. And so it talks about shaman and medicine men and different types of therapists through millennia. That's really all you need, right? So the idea that you're going to get some specialized therapy because someone has a certificate, it's, I'm a little biased. I think therapists are born, not made. Obviously, you can get a lot of training and be a much better therapist, but therapists have to have empathy, and that means that I put myself in your emotional shoes without feeling your emotions, and they have to have good training and good supervision. But I have a lot of patients that come in and I say, okay, so you've been in therapy for 4 years. What are your goals of treatment? And they look at me as if I have three heads. And they're like, what are you talking about? I just go talk about all the stuff that's bothering me. I'm like, okay, but you've been talking about it for 4 years and it's been the same stuff for 4 years. What are your goals of treatment? So you have to have that conversation. It's sort of, if someone came and just said, no, I just kind of do all the machines at curves and I sweat and I felt better. And I'm like, okay, You've had the same exact body for 4 years too. I guess is that fine with you? Because that's fine with me. I don't care. But you're starting strength coaches, right? So you want to do something. Like, okay, I want to have a 500-pound deadlift by the time I'm 50, or I want to be able to go on all the excursions when my cruise gets into port. And that's what you're going after. I don't know if that answers your question or not.
Yeah, it did. And there's also, in what you said, a lot of really interesting parallels between what you do and what Emily and I do. Because, of course, we, have a lot of, trainers in various fields that have like seemingly overly specialized.
Yes.
And I'll get
Yes.
clients coming in who they just need the big rocks in place. They need
Right.
consistency
Yes.
with
Yes.
exercise and some strength training. And they want to know when they should time their carbs. Like,
Right.
that is so not your issue right now.
Yeah, or you have someone come in and I'm like,
Yeah.
okay, you're on a stimulant and you're on a benzodiazepine and you're on 3 or 4 other medications. I don't really know what they're doing. Has anyone talked to you about an antidepressant? No, I don't need that. I'm like, okay. Well, so there's also a lot of bad psychiatry that happens out there. So I have a bunch of patients that come in on stimulants. They don't need to be on stimulants. They have undertreated depression because the depression affects the concentration and your ability to get through your day. There's a lot of, oh my gosh, these quack doctors prescribing kilograms of SSRIs and all they do is give you side effects. And okay, fine, but that undermines that I'm treating real illnesses and they need real medications. And I have a lot of patients that would be dead without SSRIs. So we're all trying to figure out what's important. And what's important is patient shows up, you figure out the right diagnosis, you tailor treatment, and the patient has to keep showing up, right? I mean, this is the same in your line of work.
Exactly.
The ones that show up get stronger, and the ones that don't show up, I don't know what happens to them.
Yeah, no, the ones who are consistent with their program, the ones who are consistent with their medication or their therapy, are the ones who are going to actually succeed and make some real changes in their lives. Yeah.
And at this stage of my career, it's nice because I have sort of a self-selecting population. I tell my wife, listen, I'm a really stinky cheese. Some people pay $40 a pound for this cheese. Most people just think it's kind of stinky. But the patients that like me and keep showing up, I really like working with them. They like working with me. And there's a whole process in medicine and particularly in psychiatry called the role induction. And so when I'm teaching medical students, I'll tell them about my adventures as a patient, which I was diagnosed with psoriasis, and my doctor at the time, and I also caught tuberculosis in an Alaskan prison where I worked, which I guess is a rite of passage for most Alaskan doctors at some point. But I couldn't go on a lot of the therapies because I was getting my tuberculosis treated.
Right.
And so I could get light therapy. And so my dermatologist in Anchorage, Alaska says, take off all your clothes and put on these yellow swim goggles and stand in a UV light booth with your arms over your head a few times a week. And I said, okay. Or I blew out my ACL, and my orthopedic surgeon said, we're going to saw off the medial third of your patellar tendon and drill a hole in your femur. And I said, okay. And so there's a certain element of surrender in being a patient, right? And so I see this a lot with mood disorders. And there's something magical about the mid-30s where people say, you know what? I've been bankrupt a couple times. I've been divorced a couple times. I don't know where my kids are. I guess I'll start lithium for bipolar disorder. And so that's sort of the goal, is to get your patient to say, okay, I know that all these medicines have side effects and I don't really want to take them, but I guess I really have to.
So I know this maybe you might not be able to answer this, and it goes back to maybe we were talking about in the beginning about the stigma with medication and people being hesitant to take it, or people telling them to not take it. But as I talked to Diego about recently, somebody I know just started taking a medication, and there was definitely hesitancy on the parents' part to allow this to happen. But it was like, but your other child has glasses, and when she couldn't see the board, you got her glasses, right? It wasn't like you dangled them in front of her and said, you just need to work to see better. No. The glasses are okay. It's okay to put glasses on someone. It's okay to go to the eye doctor and get a prescription and wear glasses. But what is the issue with you're not physically, there's something mentally not well, and this will help you. This will help you focus. This will help you concentrate. This will help you, but this will bring your anxiety down. And yet there's pushback on that.
Yep.
Where does that come from?
Well, right. So with glasses, right? There's a definitive test, right? Which is, can you see the blackboard or not? All of psychiatry is some extension of human experience. So I like to talk about sort of the defense mechanisms defined by Anna Freud and how those go into what Jaspers, which is spelled Jaspers, it's spelled Jaspers, but it's pronounced Jaspers. It's sort of the really boring definitive book about phenomenology. And so you can trace something that would be a normal human experience to something that would end in actually, you're like, oh, you know what? This person's actually psychotic. And so there's a experience called personalization, which is, let's say I'm working for you at your gym and you're like, Fred, I'm on the phone right now. Can you close the door? And you need to be on the other side of it. I need some time. And I think, oh my gosh, Emily hates me. I'm probably getting fired. It must be something that I said. You know, I didn't really clean up after myself in the break room. And so that's personalization. I'm taking it too seriously. But you could quickly escalate that to, and I think Emily's going to kill my whole family and wants me to die, right? So there's this broken part of your brain, but before it's broken, it looks like normal human experience, and anybody could have those thoughts. So it's very easy to tell yourself as a story as a parent, I never had that when I was a kid, or when I did that, this is what my dad did, and I snapped right out of it. And it's a very easy place to perceive things from. And it's also and I'm learning a lot more about women as I've been married for progressively longer. So we have some, we're in our mid 40s, so we have family friends who are getting divorced because that's just the stage of life, right? And we have a friend, and the guy is stepping out on the lady, right? And my wife says, oh my gosh, I'm sure she's being really hard on herself right now, wondering how she failed him as a spouse. And I'm like, what? That didn't even occur to me. And that, but of course that's exactly what was going on in this person's head. Right. And so you're like, well, is that just how some women think, or is that depression, or is that demoralization? And you got to really know more about the case, but you could easily tell yourself a story that problem needs pills, and you could easily tell yourself a story that problem doesn't need pills. That's when, but your starting point is obviously, well, I'm depressed because my kid's being bad at school, or I'm depressed because I'm working 80 hours a week, or and so there's also the vernacular of little d depression versus the actual term of art, which is big D depression, major depression, which used to be called melancholia by Emil Kraepelin, which is, this is a real illness that you need real medication and treatment for. And it's how do you tell the difference, 2 weeks after your mom dies? Right. I don't know. I mean, I do, but you go by history and episodes, right. And previous whatever, and you're like, oh, okay, but also your mom died 3 years ago, and I don't know how long normal bereavement takes, because there's no such thing as normal bereavement, but I feel like we've crossed from a normal human experience to something that might be a part of your brain that could use some scaffolding.
It fascinates me, because I just saw someone recently, I guess it'll be a year in December that she started. And it was so clear when finally this person needed some extra help, because the talking, what was coming out of her mouth was just like, what? I'm sorry, what did you just say? Like, it just, and finally Diego and I were able to convince this person to, like, you might want to, you know what? Go see your doctor. And it was instant. It was instantaneous. The doctor was like, of course, let's just do this. And the difference has been dramatic. Again, dramatic. Sure. And it's just the smallest, again, I kind of use the dial. It's just the smallest dial. Just turn it up just a little bit. But it was enough for the edge to just kind of like, wow, I can't believe the difference I feel. Where has this been all my whole life? It goes back to that. It was, why didn't I start this earlier? Why didn't I do this sooner? But I'm doing it. I'm doing it now.
And I don't want it to sound like I'm giving everybody medication, right? So sometimes I say to somebody, oh, yeah, you've been through the ringer and this is really bad. Come back in a few months and let's see if this is still a mood that you have. and it's perfectly fine as a physician to say, you know what, you're fine. Come back later and we'll double check. But there are a lot of people on antidepressants who don't need to be on antidepressants because they just were having a bad day and cried in their doctor's office. So if you're a woman and you cry in your doctor's office, you're walking out of there on antidepressants, and that may or may not be the right thing. So I don't want to get glib about it. And I if you want a real evaluation, you need to see a real doctor. But I take an hour, and a primary care doctor is not going to have that.
Right.
So in a situation like that, where your best advice might be like, give it another 6 months, see how it goes. What are some different behaviors that you might suggest to a person in that situation that might help them take better care of themselves, take a better care of their mental health during that time period?
Right. So it really depends on the patient. So let's say you have someone who grew up in the world of pop psychology that is modern America, and they've, had a class or two, and they know what a defense mechanism is, and they know what projection is, and they know what that humor is okay. Like, if you have that kind of common ground, you can say, listen, these are the things I want you to pay attention to. And if it's a patient who's pretty motivated, I do a lot of bibliotherapy, which is a fancy word for I tell you to go read some books. So for example, I had a patient who had an injury and he was really demoralized by the injury. And I told him to read Viktor Frankl, Man's Search for Meaning, which is actually about surviving a concentration camp. And he's like, oh, my injury is not that bad. And I was being dramatic, and I'm actually fine. So the book depends on the patient and his or her motivation. Now, if you have someone who doesn't understand any psychological terms and is fairly well educated in something else, I'm not necessarily picking on engineers, but if you can't have a psychologically minded conversation with somebody and that person's got a reasonable level of education, you're never really going to be able to have a psychologically minded conversation with that person. And so that person, I treat them kind of like a hypochondriac, which is frequent, brief visits, and sort of, what are your 2 problems this week we can talk about. So books are wonderful. Audiobooks are fine. I'm always trying to find something that bridges the gap between the layperson and someone who's got too many letters after his name, like me. And the best data is for actually cognitive behavioral therapy, which is, okay, in addition to picking out goals of treatment, let's pick out the 3 or 4 major stressors this week. And then you can say, okay, now what can we do to work around that? And what can we do to work around that? And that's, you don't need me for that, but I'm good at it. And so that's what I will do in the cases where I'm like, okay, this is not a medication issue. This is a, you're working 6 jobs issue.
Yeah, that's going to be. And what if the person, I guess if the person insists, where's the line that you draw with a patient who comes to you and you're like, actually, you're pretty good. And they're like, no, I really do think I need something. Is it you just tell them to come back? Do they seek someone else? Do you think, or they say to them, I'm going to get a second opinion?
It's a free country. People do all sorts of things. Most of the time when I tell people that, they're actually reassured. And they're like, good. Oh, okay, I just wanted to make sure.
Yeah.
I do have a few patients every month that say the only thing I'll take for a treatment for my bipolar disorder is marijuana. I'm like, well, I don't really prescribe marijuana. You can just go buy it at the store. It's in Minnesota. What do you need me for? But also, did you notice that you've lost custodial rights to 3 of your kids? And I'm here if you ever want to work on that. And sometimes those patients come back. I've had patients come back after 3 or 4 years, and they say, okay, I'm ready to stand in the UV light booth with my yellow swim goggles now. Whatever you say, I don't care. It's fine. and I don't, and that, we talk a lot about, your toolbox or your golf bag or whatever comparison you want to make. So once about every 18 months, I got to drag out I'm the doctor, you're the patient, and we got to do it my way or the highway. But I don't need to do that very often.
Yeah.
A lot of times it's, we could try a little more of that or a little less of that. Or when do you want to see me again? Because you're doing fine. Or, and I that's the art.
It sounds so familiar to like what we do as coaches. You
right.
know,
I mean, I have this
yeah.
conversation with Andy Baker all the time, which is, this is what last week looked like. Let's do this number.
Is Andy your coach?
Yeah.
Oh, that's awesome. Okay. Yeah, that's great.
Nicole Rutherford coaches my wife.
Oh, that's right. She does.
Yeah.
She does.
Which I forget. I just remember that I was working at the Carroll County Jail about when Nicole Rutherford was in middle school. That's kind of how I remember. That's what I remember.
Yeah. This goes back to just Baltimore. How long, when were you in Baltimore?
I was there 2006 to 2011, and again from 2015 to 2016.
Okay. We opened up in 2011. So we were between we were open by then. We were open 2011 is when we opened. So so 2015. Yeah. So you were here when we were there. We were at the old place.
But I didn't learn to deadlift till about 2012. And then I learned that in Alaska. And then I came, all that stuff.
Yeah. This is great. I don't know if do you have any other questions, Rebecca? I don't think I have any other questions.
I had a bunch jotted down and you hit some of them and I got the others. So.
I'll pick a random one. And then we'll...
Oh boy. Emily, I don't know. Oh geez.
I think everything that I wanted to ask and talk about has been kind of nailed, hit on the head here.
Sort of generally, I guess a lot in the past few years, you hear people talking about there's a mental health crisis in the United States. I guess in the Surgeon General just declare that. Do you see a lot of differences in the last few years as opposed to when you were first getting started? If so, what's different, and what do you think are factors?
It's always been amusing to me, whether I've worked in Central Valley, California, or the Bay Area, or Alaska, or Minnesota, or Maryland. Everybody comes up to me and says, okay, I know you've been a psychiatrist for a while, but you've got to see our patients. They're really, really unique and ill. I'm like, nah, everybody's got sort of the same problems all over. I think the major thing I saw coming out of the pandemic were men and women, more women, coming and saying, I've been cooped up with my husband for the last 6 months, and this is not going to work.
Yeah.
I need to do something different with my life. And some of those patients did fine, and they figured out a way to make their marriage work. But the crisis, it's a fun word to throw around, and it also speaks to some of the public acceptance of things, right? So when I used to work at the Veterans Administration on Green Street, it was really unheard of to diagnose a veteran with depression. You had to diagnose him with PTSD. And everybody wanted the PTSD diagnosis because that means you get over $3,000 a month and a full service connection. But it also means that you're undertreating the depression, right? So all these guys wind up on blood pressure medications and nightmare medications and so on and so forth, but they're not getting their depression treated. So I worry about trends and fads, but no, there's absolutely not enough psychiatrists. There's not enough psychologists. There's not enough master's level counselors. Depression is both underdiagnosed and overdiagnosed. And there's a lot of patients I have that have been on suboptimal or non-optimal medications for a number of years just because they're not suicidal and they're sort of getting through their day, but they don't feel well. And my prime directive is I want my patients to be 100% their old selves all the way well. And it's very, very possible if you just keep showing up.
Do you treat any children or even I guess teenagers?
I'll dip down into I don't do a lot of it. I do start at age 12 and up. And there are so I'm board certified in general psychiatry, which I don't do a lot of pediatrics, but I also sometimes have patients that are like, listen, I can't wait a year for an appointment for my kid to go see a child psychiatrist. So can we get into you? And I say, okay, fine.
Yeah.
With children, the diagnoses are always really muddy because is this an early presentation of a mood disorder, or is this a parent-child relational problem, or is it ADHD? And all I know is that this kid can't be successful in a regular classroom. And so what I will say, sort of the clinical pearls about kids are anxiety is massively underdiagnosed. And there's a lot of kids that benefit from stimulants, but there's also a lot of kids that are overprescribed stimulants and would do better on an anti-anxiety level dose of an antidepressant.
Right.
And so it's a real problem. And then, the educational system is not built to do what it needs to do for each kid in a non-pharmacological way. And so there's, the minute you have to go to the principal's office 3 times, they want to send you to a different school or get you a paraprofessional or say, you just got to put this kid on Adderall. And so some of that's appropriate and some of it's not.
Mm-hmm. Do you think that many of the mental health issues with, I guess, young adults or even teenagers is a result of, well, the pandemic for one thing, but also technology?
I'm watching. So I have stepdaughters that are 10 and 14. My sons are almost Irish twins. They're 5 and 6. And I thought that they had a lot of social problems because of the pandemic. But for instance, if I have a few teenagers in my house, they all scream at each other all the time because they're used to yelling into microphones on laptops, and they don't do a lot of the human things like waiting for a pause in conversation or listening appropriately and then saying something that follows what the other person said in conversation. So somebody will be talking about one thing and then they'll chime in with, well, I just saw BTS on TV and my favorite guy is Jimin, and and you're like, well, we weren't talking about K-pop. We were talking, would you like to join a conversation? There's a whole social skill set here that you've missed an important developmental milestone because you were on a laptop for 2 years. There's a lot more gender dysphoria, and I don't necessarily want to get into the political waters on that,
Sure.
but there's a lot of that happens, and some of it is fine, and some of it is a really good petri dish for a lot of arguments and families to grow and evolve, and lots of resentments, and that's gone up a lot.
Mm-hmm. Yeah, I know that definitely with in regards to my nephew, he'll change the subject. I'll be talking to him and I have to FaceTime him because, he's in Colorado. So I'm talking to him and he's showing me something and we start to talk about one thing and then I'm asking him a question. The answer is something else. The answer is, well, take a look at this hat that I just bought. And I was like, I was asking you a question about this. Okay, never mind. I guess we're moving on to the hat.
I was thinking about my thing. So I'm not an expert in that by any means, but as a parent and an observer, they're not as socially adept as they ought to be, and a lot of the bit of that is our fault.
Yeah, a lot of that is the phone's fault.
Yeah. No, I couldn't. I went to Verizon and I said I want my teenager to have a dumb phone, and my teenager acted as if I were sticking her hand in the garbage disposal. No. And then you couldn't even get a dumb phone, and now she has a dumb phone, but she never carries it and she never charges it, and because she doesn't know what it's for. I also had to walk her to a landline and show her how to dial on an old-fashioned phone, which I didn't know I'd have to do that. So we're learning.
I know. I forced Eleanor to learn how to write a check this summer.
She was like,
what are you doing? I said, she's going to write a check. He goes, who writes checks anymore? I said, I still do. And many people still do.
We went to in Minnesota, you enjoy the 2 weeks of good weather we get in the fall. And we went to some pizza farm, right? It was a big farm, bucolic setting. And they only took cash or check. And I had a folded up check in my wallet. And my wife said, you're an insane person. I said, well, it doesn't seem stupid now.
Right. Cash or check.
Right.
Should learn how to write it. Should learn how to write a check. So Eleanor did. And then she said, you can show your brother now because he doesn't know how to write a check. He was like, where are you ever going to need a check? I'm like, you will. You will. Mark my words. You will. You will.
Well, we've gone off the reservation now, but I appreciate your having me on. And I love your gym and I love your show. So I'll see you when I'm back in Baltimore.
Thank you. We hope so. We hope you visit us again, Fred. We'll be there for at least another 5 years.
Thank you so much for your time. Thank you for your time today.
Yes.
That was great.
All right.
Thank you. Thank you, Fred. We'll talk to you soon.
Bye.
Bye.
Take care.
Thanks for listening to 5x3 Radio with Emily and Rebecca. If you like our show and want to know more about 5x3 training, please visit us at www.5, that's the letter X, the number 3.com. You can also find us on Facebook and Instagram. To learn more about Rebecca, please visit her website, cornerstonestrengthmaryland.com. Thanks for listening and have a great week.